Hi, this video will introduce some information about selective dorsal rhizotomy or SDR. So what's the problem? Spasticity is one of the most common manifestations of cerebral palsy. In a study that was conducted on 97 individuals with CB, spastic CB was the predominant motor type, accounting for 90.6% of the cases, and the spasticity also was seen as a secondary motor type in 25% of children with dyskinetic CB, and in 18% of children with ataxic CB. Spasticity can interfere with range of motion, resulting in functional limitations and development of contractures. So another study showed that spasticity was significantly related to the development of muscle contracture, which was measured as reduction in range of motion. As you see in the picture, the range of dorsiflexion of ankle joint decreased during the first 18 years of life, and the range of motion of dorsiflexion was lower in children with higher level of spasticity when measured by Ashworth scale. SDR is one of the commonly used surgical procedures to reduce or eliminate spasticity in the lower extremity in ambulant children with CB. Typically, the neurosurgeon performed laminectomy to expose cauda equina. After that, the neurosurgeons separate sensory root from motor roots. They divide each dorsal or sensory root into rootlets. Then they stimulate the rootlets to record the electromyographic response of the corresponding muscle in lower extremity. The dorsal rootlets associated with severely abnormal response are divided and cut. So, sectioning of these rootlets reduces the efferent input within the spinal cord, which reduces the excitation of the alpha motor neuron, resulting in reduction of spasticity. Two different techniques are used for SDR, single-level and multi-level laminectomy technique. In the literature review of a retrospective case series study, researchers stated that neurosurgeons consider multi-level to be technically less difficult than the single-level technique. However, with using the single-level technique, they can avoid the complications of progressive spinal deformities. The multi-level technique creates a scar length of approximately 12 centimeters, while the single-level technique creates a scar of only 5 centimeters. So, in this study, in the multi-level technique, the laminectomy was performed from L1 or L2 to S1. In the single-level technique, the surgeon exposed the tip of conus medullaris, which is the end of the spinal cord as you see in the picture, and the start of cauda equina. This operation required laminectomies for 1 or 2 levels between T12 and L3. Using the microscope, the dorsal roots from L2 to S1 were separated and transected. They found that no significant differences existed between the single-level group and multi-level group in terms of post-operative pain and time of mobilization. However, the length of hospital stay was significantly decreased in the single-level group. Now, do children achieve better outcomes if they receive intensive physical therapy before the surgery? Here is a randomized control trial. It was conducted to determine whether the additional intensified physical therapy prior to SDR improved long-term motor outcome. So, it compared the outcomes in 2 groups of children, 13 children in each group. The assessment was performed for both groups at baseline. Then the first group had SDR and received post-operative intensified physical therapy for 9 months. After that, the assessment was performed. The other group received 9 months of intensified pre-operative physical therapy followed by SDR, and then a further 9 months of physical therapy also. And again, the assessment was performed after receiving the physical therapy program. Here, a previous randomized control trial compared between both groups and concluded that children who received the pre-operative physical therapy made functional gains faster than the children who didn't receive intensified physical therapy before SDR. In this study, the follow-up assessment were performed at a mean of 53 months after SDR for both groups. And here is some information about the physical therapy protocol they used. Here in the table, you see the changes from the baseline to the late assessment or the follow-up for both groups and GMFM scores and in modified Ashworth scores and range of motion, which was assessed with goniometer, and the strength, which was assessed by the Medical Research Council grading system. So 6 patients in group 1 and 3 in group 2 had orthopedic procedures on the lower limbs between the time of SDR and the delayed assessment. So their data were excluded, and then the mean changes in the GMFM were less for both groups 1 and 2. So the findings in the longer term indicated that the additional preoperative physical therapy didn't improve the motor outcome measures or the range of motion, the spasticity, or the strength. Patients who received orthopedic procedures seemed to have a greater improvement in the GMFM than the remainder of the patients. And these findings suggested that the orthopedic procedures done after SDR may have a significant positive impact on the functional motor outcome. Here is a study that was conducted on 14 patients with spastic diplegia. 2 dimensions of the ICF model were assessed before SDR, a year, and 20 years after SDR. The first dimension of the ICF was body structure and function in terms of muscle tone, joint stiffness, and voluntary movement. The second dimension was activity that included assessment of a gross motor skills such as sitting, walking, and transition. All patients received intensive physical therapy before and after the surgery, and the functional outcomes based on both dimensions improved significantly a year after SDR, and these changes were maintained at 20 years after SDR. Also, there was an improvement in gross motor function classification system levels a year and 20 years after SDR. This is a picture for one of the participants before the surgery, a year after the surgery, and 20 years after the surgery. You can see the improvement in range of motion of hip flexion, knee extension, and head and trunk control. But as you see, one of the limitations of this study is including a small sample size. Another study investigated the long-term effect of SDR on 29 children aged between 2 years and 12 years. The results showed that there was significant improvement between baseline and 5 years after SDR in the gross motor function major scores. But no significant differences were found between 5 years and 10 years after the surgery. In 10 out of 28 patients, there was more than 20 centiles improvement in motor function 5 years after the surgery. And after 10 years, there was improvement in 6 out of 20 patients. No deterioration has been found in any child in a gross motor function. 2 patients had spinal side effects such as scoliosis, spondylolysis, and spondylolisthesis. And 16 patients required orthopedic surgery. So this study showed that additional intervention after SDR was required. And this is a study that was conducted on 29 children who underwent SDR and received physical therapy. 10 years after the surgery, muscle tone and hip flexors, adductors, knee flexors, plantar flexors was normalized. And you can see in this table the proportion of participants with normal or hypotonic muscle tone according to the modified Ashworth scale pre-operatively, and the proportion of participants with normal or hypotonic muscle tone after 10 years. And you can see the differences for each muscle group. There was no significant changes in passive range of motion, but there was improvement in gross motor function as measured by gross motor function measure scores. In contrast to the previous study, the participants in this study underwent surgery after age 10. Participants were categorized into 3 groups: SDR group, orthopedic surgery group, and no surgery group. Functional declines have been found in SDR group compared to other groups. And gait improved in the orthopedic surgery group only. So these findings suggest that SDR might be a contraindication for individuals older than 10 years. But again, this study was conducted on 26 participants only, which is a small sample size. A study by Rose showed that there was a significant increase in quadriceps and hamstring strength in children who underwent SDR and received physical therapy, with the pre-operation scores compared to 8 months post-operation scores. And here is some information about the physical therapy protocol that they followed. As we see, following SDR, a child requires intensive physical therapy for several months post-operatively to maximize strength, range of motion, and functional abilities. They started the program twice daily at bedside on the post-operative day, on post-operation day 3. On day 4 to 7, they received physical therapy in the gym. Their emphasis was on sitting, standing balance, and creeping, kneeling, sit-to-stand, and ambulation. After discharge, they received 4 to 5 sessions per week for 8 months. So this is for the physical therapy after SDR. And for other treatment, like orthopedic surgery, I have found reference that stated that children have to complete 6 to 12 months before undergoing any orthopedic surgery after SDR. Here are the references I used. Thank you for your listening, and if you have any question, you are welcome to ask me on ACE.